Hello everyone, so today we're going to be talking about hypothermia. Presented by
Kelly Whitmire,
Ecstasy Peralta,
T. Van Nguyen,
K. Tran,
and Chardonnay Shin.
Hello there. So I'm going to be talking about the etiology and some risk factors and the pathophysiology of hypothermia. So first, it's important to know that there's two different types of hypothermia. First, there's primary hypothermia, which means you've had a long time exposure to extreme low temperature. Or hypothermia can be secondary, which is typically due to a thermoregulatory dysfunction within the body. It's also important to know that primary and secondary can occur at the same time. So I thought this was an interesting question. Why do you think elderly individuals are at risk for hypothermia? Well, you can find out on the next slide. Here is a list of all the risk factors for hypothermia. As you can see, there's a lot of risk factors. So you can go ahead and read through this list, but I'm just going to point out some ones that I thought were important. So endocrine dysfunction. So when you think of endocrine dysfunction, you need to think of the patients that have diabetes, adrenal insufficiency, hypopituitarism, hypothyroidism. So all these patients are at higher risk for hypothermia. Then we'll skip down and look at the pharmacological effects. So the drugs that affect a patient and make them more at risk for hypothermia include barbiturates, opioids, tricyclic antidepressants, and benzodiazepines. So the reason for this is that they impair the central thermoregulation and also inhibit peripheral vasoconstriction. So next we can look at sepsis. So why do you think sepsis puts people at risk for hypothermia? Well, the answer is that it causes a failure of the vasoconstriction, or it induces an abnormal hypothalamic response. Then we can skip to CNS disorders. So someone with a cerebral injury, for example, is at higher risk for hypothermia. Then we can look at the neonates, trauma victims, intoxicated patients, and the chronically disabled. So once again, the thermoregulatory mechanisms are altered in these groups. Finally, the elderly individuals. So back to our question, why do you think elderly individuals are at risk for hypothermia? So there's several reasons. First, they have a reduced ability to generate heat. They have a reduced lean body mass, impaired motility, inadequate diet, reduced shiver response to cold, reduced ability to vasoconstrict properly. They're less able to discriminate changes in temperature. And finally, they're more prone to exposure to cold through falls or illnesses. Here's another question for you. Which do you think is worse, having clothes on and being wet, or having no clothes on and being wet? Well, according to the CDC, having no clothes on and being wet is actually better than having clothes on and being wet. When you're thinking of hypothermia or thinking that a patient does have hypothermia, it is important to know what can increase heat loss, so you can prevent these from happening. So these include high wind velocity, water exposure, and direct contact with a surface. So if any of these are present and you suspect a patient with hypothermia, it is important to remove the patient from these circumstances. This is an important question because it can potentially help cue you to a patient that might have hypothermia. So if a patient has had prolonged exposure to ambient or cold environment, if the patient has sustained a trauma, or if the patient, you notice, has inadequate clothing. So in these circumstances, definitely have hypothermia top on your differential diagnosis list. This is an important topic for healthcare providers as well. Hypothermia often occurs in the hospital setting, but why? It can occur because a patient has prolonged post-op hypothermia. The patient could have received a large amount of fluids, or blood fluids specifically, that were refrigerated. Patients could have had a rapid infusion of IV fluids. And this one was interesting to me. Prolonged exposure of undressed patient during resuscitation or operative procedure. Now I will be discussing the pathophysiology behind hypothermia. First, I will discuss the normal mechanisms the body uses to keep warm. So the body uses muscle activity, so this includes shivering and increased physical exertion. Shivering can increase the basal temperature by as much as 2 to 4 times baseline. Also, peripheral vasoconstriction aids the body in keeping itself warm. However, with hypothermia, you have a prolonged or repetitive cold exposure. This leads to the normal mechanisms of the body being impaired, which leads to progressive hypothermia. This depresses physiological function. So when you think of hypothermia, you need to think of everything slowing down. So within the pulmonary system, you get a depressed respiratory drive. Also in the pulmonary system, there's impaired ciliary function, which leads to a decrease in protective airway reflex. Also, there's an increase in pulmonary vascular resistance. And also, there is a decrease in the oxygen consumption. Within the nervous system, there's a decrease in the central and peripheral nerve conduction. As the temperature falls, there is a reduction in the conduction velocity. So this is due to the decreased flux of potassium and chloride ions across the axon membrane. The synaptic delay time is prolonged as the neuromuscular junction is cooling. Also within the neurological system, you get a decreased metabolic rate. This is beneficial because you get an increased cerebral ischemic tolerance. Within the muscular system, you get a decreased ability to contract because the muscle's contraction is partially temperature dependent. Then within the GI system, you get a slowing of the gastrointestinal motility. But you also get impairments in the hepatic system and from the decreased cardiac output. And you also get a potential pancreatitis from thrombosis in the microcirculation, which leads to ischemia and necrosis in the pancreas. Within the heart and cardiac system, you get a myocardial repolarization slowing and spontaneous depolarization slowing, leading to progressive bradycardia. So if you want to look at it at a cellular level, you get a prolongation of the action potential duration. This is due to a delayed activation of the repolarization potassium current, slowed inactivation of the sodium current, and delayed inactivation of the inward calcium current. This all leads to a slower depolarization. Finally, within the coagulation cascade, cold inhibits the normal enzymatic reaction that occurs within the intrinsic and extrinsic clotting cascade. This leads to coagulopathy problems. Blood viscosity increases due to the chirofibrinogen levels becoming elevated, and hematocrit increases for 2% for every 1 degree Celsius decline in temperature.
Now, let's go over some clinical symptoms. Some general things to consider when evaluating a patient presenting with hypothermia is the fact that its early manifestations may be so subtle that the patient may not be aware that he or she is actually experiencing hypothermia. Also, as will be later elaborated on in the presentation, frostbite may accompany hypothermia. The chief complaint of the patient varies depending on the stage of hypothermia and may include the general feeling of being cold, shivering, impaired judgment or impaired coordination, high blood pressure, fast heart rate, a marked stupor, low blood pressure, slowed heart rate, a loss of consciousness, decreased breathing or shortness of breath, dizziness, or confusion.
Physical examination findings. General physical findings. Signs and symptoms are typically nonspecific and markedly variable. Some are a cold trunk, core temperature of less than 35 degrees Celsius or 95 degrees Fahrenheit. They may have a barely perceptible pulse and blood pressure, and this may cause or aggravate hypotension. There are also depressed physiologic functions. What are some depressed physiological functions? Some are a decreased respiratory drive, oxygen consumption, central and peripheral nerve conduction, GI motility, myocardial repolarization, and coagulation cascade. Mild hypothermia. This is a core temperature between 32 and 35 degrees Celsius. Some physical symptoms are tachypnea, tachycardia, hypertension, shivering, impaired coordination, poor judgment, and apathy. What is shivering? Shivering is a central autonomic response that produces thermogenesis by increasing muscle activity. As body temperature decreases, so does the metabolic activity, which may impair the person's ability to shiver, therefore decreasing heat production. Moderate hypothermia is a core temperature between 28 and 32 degrees Celsius. Some physical symptoms are the body slowing down, shivering has stopped, bradycardia, dilated pupils, slowed reflexes, cold diuresis, confusion and lethargy, and hypotension. Why is there hypotension? Hypotension is due to slowed heart rate and hypovolemia from diuresis. Severe hypothermia is a core temperature below 28 degrees Celsius. The patient may mimic death at this point. The skin may appear blue or puffy. The patient may be comatose, have apnea, loss of reflexes, asystole, or ventricular fibrillation. Pediatric exam findings. Children having hypothermia may show as pale or cyanotic. Their pupils may be fixed and dilated. Their muscles rigid, there may be no palpable pulses, and the heart rate may be as low as 4 to 6 beats per minute. Prolonged hypothermia physical exam findings may include dysrhythmias, conduction abnormalities, acidemia, hyperkalemia, rhabdomyolysis, pulmonary edema, chronic kidney disease, pneumonia, pancreatitis, hypoglycemia, hyperglycemia, and coagulopathy.
Okay, so now we're going to do the differentials for the hypothermia. So here's the differential diagnoses for hypothermia. So one of them is metabolic causes, which can be confused as hypothyroidism, hypoadrenalism, and hypopituitarism. Sepsis, because it alters the hypothalamic temperature set point. Severe dermal disease, significant burns, exfoliative dermatitis. This is because it prevents cutaneous vasoconstriction and increases transcutaneous water loss. Patients undergoing massive volume replacement, ingestions, CNS disorders and endocrinopathies, severe infections like diabetic ketoacidosis, immobilizing injuries, etc., and then it can be confused as postmortem death. This is the lab findings for hypothermia. Labs that we're going to be performing a CBC and platelets. With the CBC, you're going to see the left shift of the oxyhemoglobin dissociation curve, so it impairs the release of oxygen in the tissues. You'll get hypomagnesemia, hypophosphatemia, low reading thermometers, which you can continuously monitor through rectal, bladder, and esophageal temperature. You're going to check electrolytes, glucose, creatinine, amylase, PT, PTT, arterial blood gases due to the lower pH and elevation of oxygen and carbon dioxide. You're going to do nanograms to correct this, and you do not need to correct for the hypothermic phase. We're going to do a tox screen, plasma cortisol, thyroid hormones, BUN, liver function test, and ECGs, which has T-wave inversions. It can have PR, QRS, QT prolongation, muscle tremor artifact, and then the most characteristic of hypothermia is the Osborne J-wave, which is a slow positive deflection at the end of the QRS. So here are some other labs to perform: a chest x-ray, a UA, an ultrasonography, and a near-infrared spectroscopy. And this is to see the blood flow and oxygenation in the brain. We're going to find some dysrhythmias as well. And so with the dysrhythmias, you're going to see sinus bradycardia, atrial fib with slow ventricular response, ventricular fibrillation, and asystole. And then we're going to check serum potassium levels. It's going to be increased serum potassium with cell death, and it's hypoxic, and it's associated with no survival. Biomarkers are lactate, pH levels, and it's not significant in prognostic significance.
All right, so now we're going to be talking about treatment. First and most importantly, we are going to want to remove the patient from the cold environment, take off any wet clothing, and get them dry.
This is hopefully all going to be taken care of in the field by the EMT, paramedic, or first responder. Then they will transfer the patient to the nearest ER, all while being extremely gentle because of the irritable myocardium in the hypothermic patient, which, if they have a pulse, is extremely susceptible to converting into ventricular fibrillation. Once they get to the ER, our goal is going to first be to assess the ABCs. First, we're going to want to check for any respiratory activity or pulse. And in terms of the pulse, you really want to make sure you feel one or don't, because again, they have an irritable myocardium. So CPR in a person with any sort of pulse, no matter how bradycardic, can throw them into VFib, which we obviously do not want to do. So take about 30 seconds to a minute to be sure you either feel a pulse or don't. And once you know there is no pulse, we can start CPR. Next, we're going to do airway and breathing support, making sure not to hyperventilate the patient because a rapid fall in carbon dioxide may trigger ventricular fibrillation as well. We're also going to want to gain IV access and initiate drug therapy as needed, which will be discussed on the next slide. We're also going to want to hook them up to an EKG and core temperature measurement. Now, once you hook them up to the EKG, don't be alarmed if they have an arrhythmia, because most of these will revert spontaneously, and they usually won't respond to any antiarrhythmics anyways, because the hypothermic heart is relatively resistant to these therapies, and you could end up making things worse. As a result, once the ABCs are all taken care of, our number one priority is going to be initiating some form of rewarming therapy. So in terms of drug therapy, all hypothermic patients with an altered mental status should be given an initial cocktail of thiamine, naloxone, and dextrose. This will serve as volume expansion, and especially if they are warmed fluids, help in the rewarming process. Also, this cocktail will help us rule out any underlying causes of hypothermia. We want to avoid lactated ringers because the lactate is not going to be metabolized efficiently by a cold liver. We also want to consider administration of antibiotics, steroids, and thyroid hormone if needed. The antibiotics are especially important because hypothermic patients are at high risk for development of aspiration pneumonia, in addition to subsequent pulmonary, urinary tract, or intraperitoneal infections, and ultimately sepsis. Now, in terms of the rewarming therapy, the number one consideration in which method to choose depends on the patient's cardiovascular status. For if they have cardiovascular insufficiency or instability, including persistent hypotension and life-threatening dysrhythmias, they need to be rewarmed rapidly. And remember, I said earlier that most of these dysrhythmias will revert spontaneously with rewarming, so the sooner we start it, the better. The next consideration is the presenting temperature of the patient, because if they are suffering from mild hypothermia or temperatures over 86 degrees Fahrenheit, rapid rewarming is rarely necessary, and most of these patients will be able to rewarm on their own, simply by endogenous means of heat production, such as metabolic heat or shivering. So this technique would be considered passive rewarming, where we get them dry and insulate them, but then let their bodies do the rest of the work. This avoids rapid changes in cardiovascular status, so it has the least associated risk. There are two types of active rewarming. The first is active external rewarming. This basically is an adjunct to passive rewarming, but here we are giving them heating pads and wrapping them in heating blankets as shown below. We are also immersing them in warm water baths, placing them under heat lamps for radiant heat, and putting them in the pathway of heated forced air. The second type of active rewarming is active core rewarming. This involves more invasive procedures and is therefore reserved for patients in whom hypothermia is severe, i.e. those who have had profound hypothermia for long duration with underlying debilitation, those who have respiratory or cardiovascular instability or insufficiency, or those who are in cardiac arrest or ventricular fibrillation. The exception to this are the two less invasive active core methods involving inhaling warmed, humidified air or heated IV fluids, both of which should be considered in all hypothermic patients because, again, they are non-invasive and therefore have few complications as long as the temperature rise is well controlled. The more invasive methods involve a warm saline lavage of various internal organs, such as the GI tract, the bladder, the peritoneum, or the pleura. There is also the mediastinal lavage by thoracotomy, but this has high risk and is reserved only for those in cardiac arrest. Finally, the gold standard of rewarming a cardiorespiratory compromised or arrested patient is going to be the extracorporeal rewarming, which is sort of a heated dialysis, if you will. So in this method, shunts will route the blood to a warming device and then return it to the patient's body. Now, of course, with any therapy, there can be complications and side effects. And in the hypothermic patient undergoing any active rewarming, we want to watch for core temperature after drop, in which the core temperature continues to decline even after rewarming has begun. This is one of the more common complications. The incidence of this complication can be reduced by active external rewarming of the trunk, but not the extremities first, and avoiding any movements by the patient to keep the cooler blood at the periphery. We can also get various other complications from rewarming. Again, the ventricular fibrillation and other arrhythmias is a possibility due to the irritable myocardium. Acute respiratory distress syndrome can occur, as we know, from sepsis most commonly, and as I mentioned earlier, the hypothermic patient is going to be prone to infections and subsequent sepsis if not treated appropriately.
This portion of the presentation will be focused on frostbite. What is frostbite? Frostbite occurs when extreme cold causes damage to the skin and its underlying tissues. It may occur on skin anywhere on the body, but is generally limited to the distal portion of extremities, face, nose, and ears. Here are some general considerations. A few that I'd like to point out include the fact that frostbite occurs when skin temperature is less than 0 degrees Celsius. High-risk groups include outdoor workers, the elderly, the homeless, people who abuse drugs or alcohol, and those with psychiatric disorders. Also, frostbite may result in permanent tissue damage. Risk factors that may predispose someone to frostbite are alcohol consumption, smoking, inappropriate or constrictive clothing, prolonged stationary posture, use of protective ointments, medications affecting circulation, touching cold materials, and wetting of the skin. Also, certain disease states like PVD, atherosclerosis, and diabetes are risk factors. Frostbite is categorized by degree of injury. In first-degree injury, also known as frostnip, the patient may complain of stinging and burning, followed by throbbing. In second-degree injury, the patient may complain of numbness, later followed by aching and throbbing. In third-degree injury, which has a poor prognosis, the patient may complain that the involved extremity feels like a block of wood, which is later followed by burning, throbbing, and shooting pains. In fourth-degree injury, where the prognosis is extremely poor, the patient may complain of a deep, aching joint pain. Prior to admission to the hospital, first responders should refrain from thawing until the risk of refreezing is eliminated. Also, it is important to have pain meds on hand, since the rewarming process is very painful. Once the patient gets to the ER, rewarming should be initiated as soon as possible. The injured extremity should be placed in gently circulating water at a temperature of 40 degrees Celsius for at least 20 minutes until the extremity is pliable and erythematous. Blisters are treated with topical aloe vera cream every 6 hours. Affected digits are separated with cotton and wrapped with sterile dry gauze, and elevation of the involved extremities will help decrease edema and pain. And lastly, if wet gangrene or infection complicates recovery, amputation may be unavoidable.